Hi, everyone, and thank you so much for joining us for our virtual health event with UC Health. I'm Hannah Strepfer, and I'm representing the Highlands Ranch Community Association, and it's a pleasure to have you all here tonight. We truly appreciate your presence as we delve into the topic of the myths of menopause and women's health. We're also thankful for the support of UCHealth Highlands Ranch Hospital as our valued community partner in making this event possible. Before we get started, I would like to go over a few housekeeping items. We are recording the webinar this evening, and we'll be sending this recording out within a few days. During this webinar, your microphones will be muted. To ask questions, please type them into the Q&A chat box. This can be found in your control panel on your screen. We will save the questions for the Q&A portion towards the end of this event. Our presenter this evening is Dr. Jennifer Holmes. She's a CU Medicine OBGYN. And now, without further ado, I'll pass the time off to Dr. Holmes.
All right. Well, welcome everybody. I'm going to talk to you tonight about debunking the common myths of menopause, which is a really common and hot topic right now. So I am a OBGYN over at the Highlands Ranch Hospital with the CU group and art. All right. I'm going through menopause. So if you think about it, what's going to happen next. So really, periods for a year. Menopause, perimenopause, describe this trend that your estrogen and ovaries become less associated with for regular periods. You may notice in first your weight can, you may find that you're just a little difficult, can be very subtle, pretty intense. True menopause for over a year. The age for this can range though, and for the age of 4. Long-term health consequences or just from this. Next myth is, so patient comes in symptoms, people are going to be the same. Some women will come through menopause, their period, night sweats, other such severe symptoms, their sleep is disrupted. Real say what is normal. Are they the only sign of my own little private? They can happen. May just get them intermittent. So in addition, flashes, night sleep, vaginal dryness. The big thing is there's no predicting. A lot of people, your period, other people, they might. And controlling from becoming anemic your life significant. kind of keep in mind is and about sex drive issue. Normal for some women have not so frequent intercourse as the hormone levels go. A lot of things, if your mood is intercourse is uncomfortable, or as to so the big thing was sex, one easy solution. There is an and what it evidence-based is to help libido. So different through self-exploration, with video terms and on your own. News right now to help with libido, the use of this have large amounts of testosterone, and we have to look at with this, and it's really testosterone doesn't you biofeed help with libido, and you can do that may also help myth treated. So we cannot transition to menopause. So the first thing we want is, and so if your periods are getting, if they're getting more through hormonal, surgical treatments, whether frequently may can also help with some. We find that if you're getting sleep quality is going to periods get a little bit better. And so hormone replacement really, not every person is a SSRI used to help with hot flash moisturizers or of intercourse. On hormonal management or the hot flash therapies just approved by the FDA are indicated to use, which may work very well. Myth, and so, well, so everybody will go sleep, which can lead to a variety of irritability, work, and every different. And so your life, it is and potential treatment is hormone replacement studies done, such as and hormone replacement. This on pretty much forever came out, and everybody. And then we've learned hormone replacement can many, if not most, conditions that hormone replacement cancer or cancer, you risk factor that you can't use it. We'll do the hot flashes and night sweat. Sleep quality improve, but we don't do it. And unfortunately, the weight gain associated hormones starting to. The big thing, a uterus, you can progesterone with it, build up the lining or endometrial. Don't have a uterus, and the studies do show lower risk than who have under much on a daily basis tested, because I feel so is titrated the amount value shows still having cycles day-to-day basis. Gland are going through the necessary to have as the treatment remains. There is checking, 15 the levels. It's a bit of a scam by insurance. Yeah. The big question out there in pharmaceutical. Bioidentical compounded and can become as as creams. It can compounded in a variety of bioidentical hormones is insurance. Local pharmacy level by the FDA. Commercial of these hormones, sort of they calculate how pellets can provide. So, say your testosterone low be that way, but testosterone pellets, you make where your hormones are. This can increase your risk of cancer, whether it be endometrial, menopausal bleeding. There's really no way to exactly how much you're getting. It is a reliable multiple, a patch, a cream. It can be done um, whereas the estrogen, this is regulated, is going to be the same. Is symptom control. Do not provide any that the pharmacy, they just cost hormone levels. Conclusion, menopause process that every symptom severity, your sex life, does are lots of treatments. So if you're doctor and see if you're, there's many modalities to improve. Have any questions?
Thank you, Dr. Holmes. Yes, we'll go ahead and take some questions now. Just a reminder, please be sure to type your questions into the Q&A chat box in your control panel. And I do see that we do have a few questions already. So the first question we have is, for women who suffer from PCOS, is menopause any different for them? I find that I get more regular periods the older I get instead of my usual irregular periods.
Yeah, so with PCOS, the menopausal symptoms are going to be exactly the same. With PCOS, your cycles are irregular because you're not ovulating on a regular basis. So once you become perimenopausal, sometimes the hormones, you can get more regular periods, but sometimes you don't. Eventually, as you get towards that menopausal transition, you will get exactly the same symptoms. So you can get the hot flashes, night sweats. Your periods may get closer, they may get further apart. Really, there's no way to predict.
Great, thank you. And the next one we have is for on checking hormone levels. Is there any data to support that? This person's not available. They're not finding data available, or that is true.
Yeah, so there's no data to support checking individual hormone levels and then titrating medications to try to bring those back up. Everybody's hormones will fluctuate on a day-to-day basis, like I said, depending on where you are in your menstrual cycle. And so there is no like normal range for a menopausal woman other than low. So there's no reason to say, oh, well, you need to have your progesterone up at 50 when we know that a certain dose of progesterone, whether it be 100 milligrams or 200 milligrams, is enough to protect the endometrium, and we titrate the estrogen to your symptoms rather than to the number.
Great, thank you. And the next question we have is, I have been on HRT for 14 years. How long is it safe to remain on this?
So with hormone replacement, really the goal is the lowest dose for the shortest period of time. Now, that being said, a lot of women just don't tolerate coming off of the hormone replacement. So it really just depends on what age did you go through menopause? What are your other medical conditions, which may put you at increased risk? Have you tried weaning from the hormone replacement and didn't tolerate it? I think you have to have a discussion with your doctor to see what is actually going to be best for you. Because a lot of women, if you do a slow taper off of the hormones, actually do very well once you're off of it. But if you do an abrupt stopping, all of your symptoms will come back. And so trying to just kind of find out what works best for you, it's a negotiation as far as do you want to continue it and accept the risks versus come off of it?
Okay, great, thank you. And the next question is, Can antidepressants help with perimenopause, mood changes, and anxiety?
They can. So, frequently as the ovaries become less efficient, you may notice increased PMS because the estrogen and the progesterone levels are kind of swaying further and further apart from each other. And what'll happen is your hormone levels may be completely normal for a few months and then drop down a little bit, and then you're noticing more symptoms. So, SSRIs or other antidepressants can be used in a couple of different ways. It can be used kind of the week before your period if they're still pretty regular to kind of help with symptoms, or we can use them on a day-to-day basis because it just kind of helps level out the hormones that are produced by the brain that affect the mood that can change with your periods. So they also, in low doses, several of them can help with hot flashes and such. Some can help with sleep a little bit. So it just kind of quiets those symptoms down. And frequently, once you've gone through menopause, things will just kind of stable out. And a lot of women can wean off of them after that.
Great, thank you. And the next question we have is, I have been on an IUD for many years. How do I know when my periods stop?
So average age is 51. With the hormonal IUDs, frequently you will stop having periods altogether. So typically what I'll tell people is, okay, we can take out the IUD at 51, 52, 53 years old and see if the periods stop. If the periods come back, we can always reinsert it if we need to. But if you don't need to have the hormones, then that's fine. The other thing with the IUDs that have progesterone in it, it can be used in combination with hormone replacement as the source of progesterone. As an option. So some people will actually leave theirs in, but unless it's been pulled and your body's given time to see if you get another period, there's not really a good way to tell exactly when you are fully menopausal.
Great, thank you. And the next one is, symptoms aside, do you recommend HRT for endometrial protection?
No, not just as here's something to take. So once you become menopausal, your hormone levels should drop down. And so we don't want to give you something that could potentially increase your risk for breast cancer or something like that if you're not at increased risk for things like endometrial cancer.
Thank you. And the next question is, what role does thyroid play in menopause? Can having thyroidectomy bring menopause early?
So usually the thyroid does not change when you go through menopause. If your thyroid is not well controlled, when you're having regular cycles or in the perimenopausal phase, it can cause erratic bleeding. And so it can also affect your moods and everything. For anybody who's ever been on thyroid medicine, you feel so much better when things are controlled. So it doesn't affect when your body will go through menopause, but if it's not well controlled, it certainly can make the transition more challenging.
Great, thank you. And all these questions, everyone, are awesome, so keep them coming. The next one we have is, how long will symptoms such as hot flashes last after menopause? Is system treatment going to be lifelong?
So that's a really great question. So some people will start having the symptoms maybe 8 to 10 years before their periods stop. And so they can become more frequent. And then once your periods stop, some people, the symptoms may go on for 6 or 12 months. Other people, they may go on indefinitely. So if you're on hormone replacement for symptom control, once you are menopausal, usually what we'll do is maybe 2 or 3 years and start to wean you down because the hot flashes and such will become less intense with time. And so if we do a slow taper, then usually you won't get rebound symptoms. The vast majority of people will stop having hot flashes after a couple of years, but other people, like I said, continue long term. So it's really kind of a balance of how bad are the symptoms bothering you versus the risks of taking the hormones.
Thank you. And the next question we have is, what are the internal changes during the transition to menopause that cause weight gain?
So basically, your metabolism shifts as you go through menopause. And so what used to help maintain your weight now causes kind of a slow, gradual weight gain. So you find that you have to do twice as much exercise, or you have to be super diligent about watching what you eat. Otherwise, the weight can creep up. Now, that being said, not everybody gains weight, but it is a really common consequence of going through menopause. So there's not a great fix that I am aware of, unfortunately.
Thank you. And the next question is, should you have HRT if you have no symptoms? This person had surgical menopause.
So if you have no symptoms, no, I don't recommend going on hormone replacement. Now, if you have surgical menopause and it's done at a young age, yes, I do recommend doing hormone replacement until the average age for menopause, which is early 50s, so that you're not at increased risk for things such as premature osteoporosis. But if you have no symptoms, there's no reason to go on hormone replacement.
Thank you. And the next question we have is it okay to take birth control to regulate periods at age 54?
Yes. So if you're still having regular or irregular periods, then the birth control is a really nice way to make your cycles predictable and lighter. We can do birth control, as hormone replacement later on, but it's a much higher dose than the hormone replacement dosing. So if you were to do hormone replacement dosing prior to cessation of your periods, you probably get a lot more irregular bleeding. So I would just say, yes, you can do it at 54. At some point, we would do a trial off of it to see if your cycles stop, because you will continue to get a period while you're taking the birth control. But if you stop it and then your cycles go away, you don't necessarily have to continue anything.
Thank you. And the next question we have is, can I take HRT with high blood pressure? I also had a blood clot in my eye 17 years ago. Would this be an issue?
So yes, if you have well-controlled high blood pressure, you can take hormone replacement. However, in the setting of blood clots, especially if you have like a retinal clot or something like that, we really recommend staying away from estrogen containing products because they can increase the risk for a subsequent clot. So if you've ever had a heart attack, if you've had a blood clot in your leg, in your lungs, in your eyes, in your brain, we really try to stay away from it and use other treatment options to control your symptoms.
Thank you. And the next question I have is, I've noticed my hair thinning. Is that a symptom? I see a lot of supplements advertised. Is this something that can help?
So the hormone replacement, testosterone can be a big contributor to hair loss. And also thyroid can be a contributor to hair loss. So you may find as your hormones start to decrease and become less efficient, yes, you might lose some hair, but usually it's not a significant amount. There's lots of supplements out there that may help with hair regrowth. If you're doing like testosterone supplementation, the hair growth sometimes is not reversible.
Thank you. And the next question I have is, what can I do about weight gain? Exercise and diet don't seem to be working. Is there a good medication, vitamins, or probiotic that could help?
So it really just kind of depends on what your whole global health looks like. Do you have any other things like diabetes or high blood pressure that could be treated that may help with some of that. Yes, getting regular weight-bearing exercises can help. There are some newer medications that can help with weight loss for those who are severely overweight or obese, but they're not used for women who are of a normal body weight who are just gaining weight. Weight Watchers is probably the most successful long-term weight loss program because it changes behaviors. But otherwise, I don't have a great fix, unfortunately, for the weight gain.
Thank you. And the next question is, I've read that there are very little studies on women's health, especially menopause. How does that affect treating menopause, and how much training do medical staff do for menopause specifically?
So I think it depends on where you've trained and what your experience is. There's actually a lot of data out there for hormone replacement. You just have to look for it. Not every residency program, does a lot of menopause training. I personally have done a lot just through being in practice for 20 years, but so I think just finding a provider who is, interested in hormone replacement and is willing to look at the options and willing to answer your questions and such is probably your best bet at your treatment.
Thank you. And the next question is, how long does menopause last, and how do you know it's over?
So menopause, like I said, is defined as no periods for a year. So once you've hit that transition, you will be menopausal indefinitely because you should not start having periods again after that time. It's just the symptoms that can be initial with it, and then those usually dissipate with time as well.
Thank you. And the next question is, if I've had hot flashes for months and then they stopped, will they come back again, or am I done with them?
So it really just kind of depends. As you're going through the perimenopausal time frame, you may have hot flashes, night sweats for 6 or 8 months, and then they kind of go away. But as the ovaries start to become less efficient, they can come back. Once you've stopped having periods altogether, and the hormone levels are not fluctuating as much, once they go away, at that point, they should not return.
Thank you. And the next question is, what are your thoughts on doing progesterone versus Provera withdrawal bleeds to maintain periods during perimenopause to prevent overgrowth and hyperplasia of endometrium?
So I think it depends on what your goal is. We can do daily progesterone to suppress your periods. It'll thin the lining of the uterus so that you're not bleeding. Or you can do a Provera withdrawal if you've going long periods of time without a period. When you're in the perimenopausal time frame, it's okay if you're going longer periods without having a cycle, as opposed to being in your 20s or 30s, when you're supposed to be flushing out the lining of the uterus with regular periods. So there's really no need to do withdrawal bleeds if you're doing a daily progesterone, but some women like to have the regularity of having a regular period, and so it can be done that way.
Thank you. And the next question is, what is your opinion on progesterone-only hormone replacement?
So I think the progesterone-only hormone replacement is fine. It helps some women with sleep. It may help a little bit with hot flashes. It definitely doesn't help as well as the estrogen, but I don't think it's unreasonable if you have a contraindication to estrogen to do the progesterone only.
Thank you. And the next question is, do polyps always need to be removed?
So in a postmenopausal woman, yes, we do recommend removing them. And the reason for that is I can't tell you 100% that they are not cancerous. Only 1 in 1,000 will be cancerous, but the first sign of an endometrial cancer can be bleeding, which is usually how you detect a polyp, is the bleeding. And these can be stimulated by inflammation or changes in hormone levels. And so the difference with a polyp is there's no muscle fibers in it. So if something gets irritated, it just tends to bleed. And so if we remove them, one, we can send it for pathology just to ensure that there is no signs of cancer. And two, it usually stops the bleeding.
Thank you. And the next question is it possible to have all the symptoms except changes in period? And then the period just stops one day. My menstrual cycle has not changed, but I have everything else.
Absolutely. Absolutely. So, all the vasomotor things, it's just because your hormone levels are lower. If you're still having regular periods, then the ratio of the estrogen and progesterone is still intact, but the overall hormone levels can be lower. So yes, you can have regular periods and still be miserable with all the other symptoms.
Great, thank you. And then the next one is the age of female relatives, mother and grandmother, when they went through the menopause, is that any indicator of when I will go through that?
It's usually a pretty good indicator, because it does tend to kind of be the same in families. There are certain things that can affect when you go through menopause. So smokers tend to go through menopause earlier. If you have chronic medical conditions or autoimmune conditions, sometimes you'll go through menopause earlier. So it can vary to some degree. But if your mom was in her early 40s, her mom was in her early 40s, you can probably anticipate yours will likely be in your early to mid 40s.
Thank you. The next question is, do vaginal estrogen creams contain any progesterone, or should oral progesterone be taken?
No, so the vaginal estrogen creams are just estrogen. They're only used 2 or 3 times a week typically, and the dose is low enough that you do not need to add an oral progesterone with it. If you're doing vaginal estrogen more frequently than that, you will need to add a progesterone, but usually just doing it twice a week, sometimes 3 times a week, will keep the symptoms at bay without the need for progesterone.
Thank you. And the next question is, where can I learn about herbal treatments for symptoms?
There's a lot of websites and such. Soy-based compounds or black cohosh frequently can help with some of the hot flashes and such. There's a couple of brands over the counter like Estroven or Amberin that you could get in the grocery store, Costco, Target, whatever. And so I would just do some research. The data doesn't suggest that necessarily they're super helpful, but some women do find that they are. Soy is just a weak plant-based estrogen, so that's how it works. I'm not sure how the black cohosh works, but most of the herbal supplements over the counter are a combination of the two.
Great, thank you. And the next question is, what are your thoughts on bioequivalent hormone replacement therapy pellets versus estrogen patches?
So the pellets, like I said, will give you super therapeutic levels. So when they insert the pellet, if you're doing an estrogen testosterone pellet, say your normal estrogen is 20, which is, high level for somebody who's menopausal. When we give you an estrogen pellet, your estrogen levels may go up to 500. And so you're not getting any sort of balance. The nice thing about the pharmaceutical is it's going to be a steady level of hormone every day. So you're not going to get the giant bolus of hormones, which then is what gives you the increased risk. The same with the testosterone, and the testosterone can be metabolized to estrogen. And so the testosterone pellets can cause male pattern balding, changes in your voice, which are not, don't go away after you go off of it. You can get bleeding, increased risk for endometrial cancer. So we really recommend trying to stay away from the pellets.
Great, thank you. And the next question is, should I take calcium supplements during perimenopause for bone health?
So the recommendation is 1,200 milligrams of calcium a day, whether it's through dietary or supplementation. So a glass of milk is about 200, a piece of cheese is about the same, yogurt's about the same. So if you feel like you have a well-balanced diet where you're getting adequate calcium in your diet, you don't necessarily need to take a supplement. Your bone density goes down very rapidly in the first 5 years after you've gone through menopause. So really, as you enter into that transition, you want to just make sure that you're starting from a good level. So if you can do supplementation and dietary just to make sure you're getting that 1,200 milligrams a day, then that is fine.
Thank you. And the next question is, what is the oldest age for menopause that you've had in your practice?
Late 50s.
And
So
a follow-up
probably
on that one, what is the oldest age woman you've heard of getting pregnant naturally and giving birth?
naturally in giving birth, I would say probably the late 40s. It would
Great,
be very, very unlikely to get pregnant in your 50s without assisted reproductive technologies.
Thank you. And the last question is, an unwanted increase in facial hair tied to menopause because of hormone levels?
Yes. And so the facial hair is from the hormones kind of becoming out of balance with each other. You're getting anovulatory cycles and such. And then if you add in testosterone therapy, that makes it worse.
Thank you. And we did just get one more question. Is premenopausal women, do polyps need to be removed to make sure they are cancerous or only if they are bleeding?
So in premenopausal women, they tend to just cause this prolonged spotting. You can get bleeding in between your periods. And so again, the likelihood of it being a cancer is super low. And if you can control your symptoms, with say progesterone or something like that, you don't necessarily need to get it removed. But I would say the vast majority of people do because it improves your bleeding so substantially.
Great, thank you. It looks like we've answered all of our questions. Thank you, everyone. This was a record amount of questions we've been asked in one of these events, so that's awesome. Friendly reminder, this webinar has been recorded and we'll be sending out the recording within the next few days via email. Thank you again to UC Health for giving us the opportunity to learn about the myths of menopause and women's health from Dr. Holmes. Our next webinar will be on Wednesday, November 1st, on the role of nutrition in preventing diabetes. And thank you to everyone who joined us tonight, and I hope you have a great rest of your night.